I'm going to talk about post-cataract endophthalmitis and prophylactic cefruoxime that is increasingly being used throughout Europe and the rest of the world. I have no financial disclosures. So we did a retrospective case series in 126 eyes with acute endophthalmitis after cataract surgery. We included all eyes with suspected endophthalmitis that had a vitreous biopsy taken. And for treatment protocol, we did primary tap and inject with vancomycin and ceftazidime, and a second injection if needed. And a secondary vitrectomy was performed in some cases. For outcome measures, we looked at culture results, visual acuity, and antibiotic sensitivity. And we analyzed the subgroup that received prophylactic cefruoxime at the end of the cataract surgery. So for cultures, we saw positive cultures in 73% of the cases. The majority consisted of coagulase-negative staphylococci in 53% of the cases. Then we saw 31% other gram-positives, among which several Staph aureus and Streps. And then we saw 14% gram-negatives, including two highly virulent species, being the Serratia and the Morganella. Overall, we saw an increase of total gram-negatives compared to previous years. These were visual acuity outcomes in this group. We saw a recovery of vision to 20/40 or better in 67%. We saw a poor visual outcome of light perception or less in 17%. We saw lower odds of reaching 20/40 if the culture result was other gram-positive or gram-negative, as might be expected. And also if visual acuity presentation was only light perception. For antibiotic sensitivity, we looked at the antibiotics most used in the treatment for endophthalmitis. We saw very good sensitivity in gram-positive strains to vancomycin and in gram-negative strains to ceftazidime. And in our series, 25 eyes of the group had received prophylactic cefruoxime at the end of the cataract surgery. And in 11 of these eyes, we cultured bacteria that were actually sensitive to the cefruoxime. This finding is interesting and highly suggests inoculation at a later time postoperatively, because as Ahmed also just talked about another antibiotic, but the concentration also of cefruoxime right after administration is extremely high. But it will fall under inhibitory concentrations within 6 hours postoperatively. So I come to the conclusions. We saw increased numbers of gram-negative cases, and in 20% of all cases, we saw endophthalmitis develop despite prophylactic cefruoxime. And in over 40% of these, we cultured bacteria that were sensitive to the prophylactic antibiotic. So I would like to emphasize that the duration of inhibitory concentrations of cefruoxime is limited, and thus wound closure remains essential, as I'm sure you're all aware. And we must not overestimate the prophylactic effect of intracameral antibiotics. Thank you.
I have a comment. I think you made a very good point about wound closure. So it's very important that the surgeon, when you teach surgeons to do cataract surgery, essentially you teach them to make corneal wounds if they're doing clear corneal incisions, which are self-sealing. Otherwise, you do run the risk of a lower anterior chamber during the immediate post-op. So you lose the antibiotic and you're actually sucking in with a vacuum effect anything which is sitting in the conjunctiva, and that is probably where the infection comes from.
Yeah.
Very good point.
Yeah.
Totally agree.